Good evening, everyone. My name is Dimitri and I'll be hosting tonight's webinar. In tonight's instalment of the Rural Health webinar series, we'll explore ways to upskill your practice team on how to manage common emergency presentations. The webinar will discuss the importance of a well-stocked resuscitation trolley, identify algorithms and discuss how to facilitate regular resuscitation scenarios for your practice team. Our presenters this evening are Dr. John Adey and Ariel Locock-Jones. Dr. John Adey is an Associate Professor in Urgent Care in the School of Health at the University of the Sunshine Coast. And John's clinical work has been as a general practitioner, a rural and remote GP, urgent care physician working in general practices, urgent care clinics and emergency departments in New Zealand and Australia. He's currently clinical director at a South Brisbane urgent care clinic. Ariel is a registered nurse with experience in paramedicine and critical care in both rural and tertiary facilities. Ariel has recently begun working in the urgent care environment in South Brisbane and is passionate about resource management, clinical education and care for those needing urgent or emergent medical attention in the pre-hospital setting. I would like to begin tonight's webinar by acknowledging the traditional owners of the lands on which we are coming together from and the land on which this event is being broadcast. I'd like to pay our respects to the elders past and present and would also like to acknowledge any Aboriginal or Torres Strait Islander people who have joined us this evening. Just a few housekeeping things to cover before we jump straight into it. But you'll notice that you're set on mute, and this is just to ensure that the webinar is not disrupted by any background noise. But we do encourage you to use the chat function or Q&A to ask questions. When using the chat function, we do ask that you address your questions and comments to all panelists and attendees rather than just the panelists, so that way everyone can see your questions and comments. And finally, the webinar has been accredited for 1 hour educational activity CPD. To be eligible, you must be present for the duration of the webinar. And we also kindly ask that you complete the short evaluation at the end of tonight's webinar. It should only take a few minutes to complete and will help us improve the format and content for future webinars. By the end of the webinar, you'll be able to discuss the importance of a well-stocked resuscitation trolley, identify resources and guidelines used to manage common emergencies, and briefly discuss how to facilitate regular resuscitation scenarios with your team. But for now, I'll hand it over to our presenters for the evening, Dr. John Adey and Ariel. Thank you.
Thanks, Dimitri, and thanks to RACGP for hosting Ariel and myself tonight. Thanks also for Ariel to coming along and helping us learn about emergency presentations in primary care. In a former life, I was a basketball player. That was my career before medicine, and our coaches would make us practice certain types of plays, inbounds plays from half court, from the back court, from the baseline. But one of the scenarios that we would practice is if we were down by 1 point with 20 seconds to go and we had the ball, could we manage to put the ball in the hole and win the game? And one season, it was the end of the season, it was the last game, and we needed to win this game to get to the play-in tournament. And we were down by 7 points with 1 minute to go. And then we were down by 5, then it was 3, then it was 1. And all of a sudden, we were so glad that we'd practiced that particular scenario. We ended up winning the game and making the play-in tournament. So we survived that knockout. And managing emergencies in primary care is a little bit like that. Sometimes you see a whole bunch of them. Sometimes you don't see too many at all. But unless you're practicing them, keeping up to date and thinking about it, it's kind of hard when it comes to do the best that you can do. So what we're keen to do tonight is to introduce the topic, talk about the different resources that we need in our general practice, Look at the resus trolley because it's important that we get touches of the resus trolley. Look at escalating scenarios and also handing over to our colleagues. Then we're going to look at a resus scenario. So we've videoed that today because that's the sort of thing that I'd like to see you doing. And then we're going to go through some algorithms and protocols. So what we're hoping is that you'll be able to look at what we're doing, reproduce it, and use some of the information from the algorithms and protocols to keep up to date. One of the things that I've found through my experiences in emergency department, general practice urgent care centers, especially in leadership roles, is you do get a lot of complaints and things do go wrong from time to time. And I find that if you're managing scenarios like this and you're talking about them, there's a lot less chance of things going wrong. We don't hear too much about emergency management in primary care. And one of the reasons is the coding. And this is what I found in the last 7 years when I was doing a PhD in urgent care, is presentations to emergency department are coded according to the International Classification of Diseases 10, whereas presentations to primary care are basically coded with the ICPC, the International Classification of Primary Care, introduced by Wonka. What I found with the PhD research was that I had to go and look at all the presentations and translate them to ICD-10, and then I could compare apples with apples, and we could make some comparisons. And what I found, and this was an article we published last year, comparing ED to urgent care to after-hours general practice on a Sunday over a year on the Sunshine Coast, was that 2ED, you had 14% of presentations were infection, 44% injury. In general practice, it was 48% infection, 8% injury. And in urgent care, it was 55% infection, 20% injury. So once I understood that you needed to speak the same language to compare, all of a sudden, it was amazing how many emergencies that we actually saw. And we did compare it to the BEACH study. So the BEACH study, as we know, is the Bettering of Health Evaluation and Care of Health. It was one of the most reliable studies in Australia with nearly 2 million encounters between 1998 and 2016. I could find lots of lists of what came into general practice for day-to-day things, but I couldn't find much about emergency presentations. Last month, I looked at a German paper. I was having to review that. And basically, the start of the name of the title was "What You Don't Present Doesn't Exist." And basically, their thesis was the whole thing about the role of general practice in acute care is not described very well. And that's really because of this ICD-10 ICPC kind of disconnect. And what they said was the absence of published data on the amount of acute medical cases cared for in general practice cannot be explained by their non-appearance in GP practices, because once the GPs close, the emergency departments get busy. So I think we manage a whole lot more emergencies than people give us credit for. Here's a study that I did find. It was 2001, so it's a long time ago, looking at the emergencies presenting in the last 12 months to general practice. This is what GPs managed. And you'll see this list. There's a lot of things that you'll be familiar with. So acute asthma, we'll talk a bit about that today. Psychiatric presentations, convulsions, hypoglycemia, anaphylaxis, we'll be talking about that today. Shock, poisoning, those types of things. But there's not a lot. So I'm hoping that in the years to come, that's certainly what I'll be looking at. When we're starting to manage emergencies in general practice or get serious about it, it's important to have reference materials. So one of the ones that we have is Tintinelli's Emergency Medicine. I like to have hard copies because if the computer goes down and I don't have access to the internet, then at least I've got a textbook. And this is what we used when I was working in emergency medicine at Royal Adelaide Emergency Department. Another great reference is the Primary Care Clinical Manual. So this is a Queensland Health Initiative, pretty much 800 pages, and they update this every 2 or 3 years. So there's not many Australian references like this. What we've actually done is we've printed it out and we've got the chapters. So there might be a chapter on cardiovascular emergencies. There might be a chapter on obstetric emergencies. And I find that really helpful. So we printed that out and it's in the doctor's room. Another resource that I've produced is a policy and procedure manual, and I get help with this from my team, including Ariel. So what I've done in the 12 urgent care centres I've set up around Australia is that I write something like this. A, it's a good thing, but B, especially when you're traveling around, I might know what to do, but sometimes I don't know the local scenarios and who's the local person to refer to for different things. So I've just highlighted a few things there. The first is our surge protocol, because sometimes where I'm working in urgent care, you might get 12 people turning up. And one time we had 12 people turning up. One was an ambulance diversion with a semi-conscious head injury from the day before and a witness snake bite, and things can turn to custard pretty quickly. So we've got a protocol for that. We've also got a protocol of places to refer. So we refer to the Children's Hospital, hospital in the home, local pathologies, radiologies. So it's a little bit of information on that. And also information on specific presentations. So not that I see too much of acute presentations for meningitis. I have seen it a number of times through my career, but I always forget the dose of penicillin. So I've put that in there. This is from the Queensland Primary Care Clinical Manual. And I also always forget the dose of anti-D and when I need to give it. So I've cut and pasted that. So I encourage you to do one of these for your local area so that if I ever have to do a locum there, I won't have to worry about which number to ring for certain emergencies. The next thing I wanted to talk about was the resus trolley. And when I spent some years at 4Health, starting urgent care there in their network of 84 clinics, I was very lucky in the sense that they let me be medical director over a number of clinics, but they also flew me around and we ran resus scenarios in different practices so that doctors could get touches of the resus trolley, so that when emergencies came in, it wasn't such a scary thing. And one of the things that I've noticed with resus trolleys and also equipment on resus trolleys is that we've got a whole bunch of different skill sets with doctors and nurses. So some doctors have just come out of emergency department, some have just come from anesthetic runs, some have come from satellite hospitals, some are country GPs. And it's something that we kind of found very interesting when we set up this urgent care centre here. I was very lucky that we have Ariel and she works 1 day a week in ICU. So she's managing a whole bunch of these emergencies a lot more than what we are. But she's also a paramedic. So we've learned a whole bunch from her. But she was really crucial to getting the resus trolley all transformed where we are. And I'm going to get her to talk a little bit about the experiences with that and the experiences of the different skill sets of the doctors here and how you have something that's kind of safe for the patients and safe for every doctor that works in the practice.
Thanks, John. So yeah, coming from ICU into the urgent care setting and looking at a resus trolley that had minimal drugs and was absolutely chaotic was a real big shock to me, because in ICU it is very structured and organized. So I started researching rural and remote guidelines for how they stock their resus trolleys. And I also looked at the RACGP's doctor's bag and what sort of stuff they recommended GPs to keep on hand. So from there, and in discussion with John, we formulated a list of what sort of equipment we should have available and also what medications we want on site for urgent care.
And here's that list. So we've got two resources there. The first is the AgPal guidelines for basically the resus trolley and also the doctor's bag medications that we're able to get each month. The second was the Rural and Remote Emergency Services Standardization resus trolley. And I've put in there in red the things that Ariel and I talked about, and I'll get her to highlight especially one of those things that we talked about and the solution that we came to.
So everything in red is what we decided wasn't suitable for an urgent care setting. It was just way beyond our scope. The medication, however, that was an interesting discussion and is ongoing is metaraminol. I personally really love the effect of metaraminol and sometimes think that giving fluid boluses just doesn't quite cut it for that really hypertensive patient, especially when you're not sure how far away backup is. However, as John pointed out, in the primary healthcare setting, most people haven't touched metaraminol recently, if not at all. So there could potentially be a bit of a skills and scope misalignment with stocking that in a resus trolley in this setting.
And the great thing about running regular resus scenarios, so when I was at 4Health, I was able to do this every month for our doctors' meetings. We would put the resus trolley in, we'd pick some of the scenarios that I'm presenting today, and we would ask a doctor to be a mock patient, a doctor to be obviously to be a doctor, and we'd have nurse in there, and then we would talk about the particular case. And when I look at this list, what we've done as a result of the discussions with metaraminol, because we've got some of the doctors that have worked in, that will still work in emergency departments and ICUs, is we're running a postgraduate certificate of urgent care through the University of the Sunshine Coast. We've got people, we've got the urgent care reps from ASIM, ACRM, RACGP, Royal New Zealand College of Urgent Care, Australasian College of Nurse Practitioners, and Paramedicine, the World Organization of Family Doctors, and we've got the disaster management person from the WHO. So we're preparing a course, and as a result of the discussions between Ara and I, we're having teaching on metaraminol, after which we might be putting it back on the resus trolley. So it's important to have these discussions, and also stuff changes. You know, when I was at 4Health, some of the stuff that previously was on the resus trolley was taken off. Another thing that I find really interesting is, doesn't matter, you know, if you've agreed on your list, you often have staff coming and saying, can we have this piece of equipment? Can we have this medications? And sometimes they can be quite costly. So talking about these types of issues at the management meetings was very helpful. So what I want to do now is just show you Ariel's work. This is a pretty nice looking resus trolley, and I'll just get Ariel to talk through this with you.
So this is the resus trolley that we have in the urgent care clinic here. As you can see, it's all very neat. There's minimal clutter on top, and everything that you could possibly need in an emergency presentation or the deteriorating patient is on this trolley. So you only have to go to one place, you only have to collect one piece of equipment, and you are set.
And we share this with the general practice because you know, we don't use it too often. And you'll notice there, just at the top of the resus trolley there's a folder to record, you know, observations and notes. You'll also see on the left-hand side there's some algorithms. So pretty much what we do is we have all the algorithms there. So if you're not quite sure what to do, there you go. And I've listed those algorithms there so you can print those out for yourself and put them on your resus trolley as well.
So all of our drawers are labeled, and they kind of go in order of your doctor's ABC that you would be doing anyway, or your primary assessment. So top drawer being medications. These we want to keep to just primarily your first line medications or ones that you're going to need in your emergency situations. We don't need Panadol on a resus trolley, but we do need adrenaline, for instance. Moving on to the second one, we've got our basic airway management. Is that going to the next slide?
There we go.
Okay, so this is our medication drawer.
And you can see we've got an anaphylaxis pack there. So the number of places that I've worked have that. Just makes it nice and easy because it's one of the more common ones that we have.
So our basic airway drawer, you can see we've got some nasopharyngeal airways and some OPAs, as well as just some basic suctioning stuff as well. Onto our advanced airways, you might notice that we don't have any ETTs, but we do have LMAs.
So remind us of the thinking behind not having ETTs on our resus trolley.
So the thought process on not having ETTs on our resus trolley is that it might have been a significant length of time before the doctor had previously done an ETT or used that piece of equipment, and there is a high risk of error in that, whereas LMAs, there is a very low risk of error, and also any nurse who's ALS trained can insert an LMA as well. And
in my Royal Adelaide Hospital Emergency Department days, often we would go up and spend a week with our anaesthetic consultants putting tubes down once a year. I haven't intubated somebody using an intratracheal tube for a number of years, and I'd be a little bit scared about putting it down the right main bronchi or you know, not having the skills that I used to have. So onto our breathing drawer. So we've got all of our bag valve masks from neonatal up to adult.
We've then also got all your forms of face mask and nasal cannulas from neonatal up to adult as well. So our circulation drawer, this is where you want to get all your access, all your cannulations, basic syringes, as well as fluids and giving sets as well. And then the bottom drawer is a bit of a miscellaneous drawer. This is where we want to keep PPE, things like space blankets, shears, spare sets of equipment like stethoscopes and a manual blood pressure cuff as well. On top, we have a green frog defibrillator, so an AED. We don't have a manual defibrillator on site at the moment.
In New Zealand for urgent care, the standard is a AED with a manual override, and I'm thinking that's probably the way it's going to go in Australia for urgent cares.
Yeah, I agree with that.
Next thing I want to talk about is the basically PACE and ISBAR. Well, I'll get Ariel to talk about that because this is what I've found sometimes in my career, and sometimes me being me. Sometimes there's 6 people, 10 people in the waiting room. You're working really hard. Your mind's going a million miles an hour. You just want to finish the next case before you go on to the one that you're being asked to see. But sometimes the one you've been asked to see is like a life-threatening condition. And the interesting thing about PACE is a lovely graded way where a nurse can progressively ask you in a progressively, well, I wouldn't say aggressive, but basically a way to get your attention. And then the next one is about handing over to our paramedic colleagues, because the way I see paramedics, especially working with in the paramedic school to write this postgraduate certificate of urgent care, is that paramedics have amazing skills. They intubate a whole bunch more than I have in the last sort of 5 to 10 years. And what I try and do is to treat paramedics with as much respect as I can. Take a chest pain, for example. I always like to put a drip in, document the medications that I've given, write a letter, do a handover, and respect them as professionals. So I'll just let Ariel talk about PACE and then ISBAR.
Beautiful. So communication is a really important non-technical skill that's really paramount for effective crisis resource management and patient safety. It's often been rationalized that effective communication between hospital, allied health, and primary healthcare professionals improves the quality and the continuity of care for the patient. However, despite this seemingly known fact, communication in the pre-hospital setting, whether it be between the GP and the practice nurse or between a paramedic and an allied health, is often quite poor, with no clear set expectation or gold standard for this interprofessional communication. In my experience as a nurse and as a paramedic, I can attribute that handovers in the primary care environment are often really clunky and there's key information missing or forgotten. There's been really big movements in universities recently to now teach structured handovers and graded assertiveness to help improve this known deficit in communication, not just in the primary healthcare setting, but in healthcare in general. So just more specifically to touch on PACE, it's a tool that was first introduced in the surgical setting to help redirect or refocus surgeons who were tunnel visioned or fixated on one task and were potentially missing a really key or critical aspect of patient care. This tool is now being taught to most healthcare professionals as a way to escalate their concerns regarding patient care or patient safety as a whole. So PACE stands for Probe, Alert, Challenge, and Emergency. So what you're doing is you're escalating your level of communication if the person you're speaking to is not understanding the level of concern that you're trying to portray. So just diving into that a little bit more specifically. So P for probe, this is where you want to seek clarification in your communication. Did you know that this is happening? Hey, did you notice this vital sign is a little bit low? In alert, if they're not quite cluing on to that previous statement, you want to offer options or alternatives that will potentially resolve this situation. So for instance, hey, this patient's hypertensive. Do you want me to give a fluid bolus now? You're offering the resolution. Failing that, you then move up to challenge. So you're really expressing concern. You're asking questions. So I'm really concerned that this patient is hypertensive. Can you please explain why we're not managing this right now? And then E, emergency. This is where you go, for the safety of the patient, you need to stop what you're doing right now, and we need to focus on this. So you're using really direct, to the point language here. Graded assertiveness as a whole is a really vital communication tool that empowers healthcare professionals to address concerns and advocate for patients and promote a culture of safety. By incrementally adjusting the assertiveness of their communication based on the urgency and the response of their recipient, healthcare professionals can foster a culture of open dialogue, collaboration, and accountability, whilst also just mitigating errors and improving patient outcomes as a whole. I think GPs can often forget that sometimes nurses and paramedics have a whole different bunch of skills and knowledge that can be really beneficial to use in these stressful scenarios. And it's really important that any healthcare professional feels empowered to be able to ask questions and escalate their concerns. The level of confidence of healthcare professionals in the primary healthcare setting, whether it be GPs or nurses, to use graded assertiveness techniques to escalate their concerns is only going to increase with education and further acceptance that this is an okay technique to use, and it's not met with dissatisfaction or reprimand for trying to speak up, essentially. Back to you, John.
Oh, that's good. And look, just with PACE, I often tell the staff that I work with, if you're worried about something, just ring me up and say, John, get your butt in here now. You know, I'll just do it. I just like people to just start off. If you want me, just tell me. But this is a nice thing, and it just is graduated. So the whole idea is not to cause offense. The next thing we want to talk about before you get to see Ariel and I in a resus scenario is the ISBAR. So this is when we're handing over to our paramedic colleagues, especially when we're wanting to get them to transport a patient.
So as someone who gets handed over to really regularly, not just as a paramedic, but as a nurse as well in urgent care and in intensive care, there's nothing more frustrating than receiving a really clunky, unfinished handover. It leads to delay in care, it increases the potential for mistakes to be made, and it just makes everyone just a little off their game. I recall attending a GP practice as a paramedic to transfer a hypotensive patient, and the only bit of clinical information we got given was that the blood pressure was 100 over something. Lo and behold, when we did that first set of vital signs, the blood pressure came back with a systolic of 130. It wasn't really until we started probing the doctor, who'd then started seeing another patient, what the go was. Turns out they'd gotten IV access and given some fluids, which is an absolutely fantastic intervention, but we've now just wasted 10 minutes trying to figure out what they've actually done and how this has been resolved. So there's been a lot of research suggesting that patient safety and outcomes have improved since the introduction of standardized handover tools. Some of the most common structured handover tools used in Australia at the moment is Shared, ISBAR, or IMIST AMBO. They all achieve the same results, so I would really encourage everyone to just pick one that they like and just stick with it and keep practicing with it until you know it off the top of your head. I personally prefer using ISBAR, and that was the one that I was taught in university as well. So ISBAR stands for Identification, Situation, Background, Assessment, and Recommendation. This can take all of 5 minutes to organise a systematic approach to your handover, and it makes a massive difference to the person receiving the information as well. So I'm not sure they can see this screen. So as you can see on your screen, this just breaks down what's expected in each category. You don't need to tell them the patient's whole life story. You just want to keep it short, simple, and to the point. So identify, you want to say your name, your role, and most importantly, why do you need to talk to this person, and are they the right person to talk to? In the situation, you want to know the patient's age, you want to know their gender, what's their primary complaint, or why are you concerned? Why have you called for help? In their background, you really want to highlight on if they have any allergies or just relevant medical background to this presentation right now. So for instance, with a cardiac chest pain, I don't need to know that their second auntie twice removed is allergic to cats, but I do need to know that this person's had a previous MI 2 years prior. Also in background, you also just want to touch on how did they get into your situation now. So have they come into urgent care themselves? Have they been driven by a friend? what is the actual situation that's led to you calling. In the assessment, you want to make a brief sort of diagnosis of what you think the problem is, and you want to tell them all of the vital signs, any other diagnostic tests that you've done, as well as any other interventions you've done as well. So main thing being, if you've given any medications, highlight that, the dose and the time that you've given it, so we know where to pick up care from. In recommendations, what do you think needs to happen next? Where do they need to go? Do they need to go to the specialised tertiary centre, or can they go to the local ED down the road? And most importantly, you want to give them a solid 30 seconds to a minute to process what you've told them and ask them, do you have any questions, queries, or concerns? This gives them the opportunity to just revisit information and make sure they've got everything correct. That's all good. I missed AMBO. I haven't used this technique in a long time, but as you can see on your screens, this is what's commonly being taught now to paramedics going through university. It highlights really how many seconds of pause that you need to give after a handover, and it's important to revisit the information being told.
So what you're saying, Ariel, is that if I'm handing over to a paramedic, they're actually kind of expecting this type of order, and sometimes if I might give it in a different order, it kind of might throw them a little bit.
No, not necessarily. So whether you use IMIST AMBO or ISVAR or shared, they all deliver the same information. The main thing is that it's in a systematic way. So paramedics are really good at interpreting your handovers. They can interpret an ISVAR handover and adjust it into their own IMIST AMBO.
Oh yeah, that's what I'm saying, but it's using one of these kind of handovers would be a good thing for us to do.
Absolutely, yes. Not using a structured handover tool creates a lot of chaos, and it just leaves a lot of opportunities for mistakes or information not getting passed across to ED.
Great. All right. So one of the things that I started doing at 4Health was to run these resus scenarios every month. And what was interesting is they had 84 clinics around the country, and each of the general practices was different. And what we did was we managed to get a lot of the resus trolleys around the country the same. The protocol's the same, the drug's the same, and then it was just a matter of getting people into the resus trolley to have touches and to rehearse scenarios, and so that when these situations would come in, they would be able to manage them. So what we've done in the next slide here is to do a little role play. So I'll just put that on for you for 7 minutes, and then we'll get into some scenarios after that.
All right. Hey Jane, what brought you in today?
I was out at lunch at a local cafe and I had some food, and now I started coughing and complaining of itchy. My friends brought me here.
Okay, are you allergic to anything at all?
Nuts.
Okay. Is there any chance that you've been exposed to nuts before?
Maybe.
Yeah? All right, do you normally carry an EpiPen?
No.
No, okay. Let's do a set of obs on you. And I'm just going to call the doctor in here. Just because I think you might be having a bit of an allergic reaction. Hey John, I've got a 44-year-old female in here. She's been out at lunch today and is now coughing, complaining of an itchy throat. She does have a history of anaphylaxis to nuts, but doesn't carry an EpiPen.
Right.
First set of obs are just coming back now.
What you got there for the odds?
So we have a heart rate of 115.
Oh.
Blood pressure of 95/50, respirator 24, SpO2 of 96, and a temp of 36.8. And she is currently a GCS 15.
Right. Are you otherwise healthy besides what we've mentioned before?
I've got hypothyroidism.
Right. Any medicines you're on?
No.
No. And obviously the nuts, I think I heard that before, that you were allergic to nuts. So I'll just have a quick listen to your chest at the back there. And what am I listening to here? Can I hear anything in the chest?
You can hear a bilateral wheeze.
Okay. All right. And just any asthma or beta blockers or nothing like that we have to worry about? So I'm a little bit concerned that you might be having an anaphylactic reaction here, because you've had that in the past and you've got some cardiac symptoms and some respiratory symptoms. So what we need to do is to get some adrenaline and just inject that into your thigh, and we're going to inject it into the muscle. So we want it to work correctly. Is that okay? And what I'll do in the meantime there is to grab a drip and put that in. So I'll just wait for the adrenaline pack there.
Beautiful. So I've got some adrenaline here. Can I just confirm the dose of adrenaline that you want to give?
Yes, so 0.5 of 1 in 1,000 into the thigh and intramuscularly.
Beautiful. So 500 milligrams of adrenaline, and I'm going to pop that into a thigh now.
Great. And I'm just going to get the circulation. It's not great that we've got this all set up here. So I've got the little trolley there, and we won't put it in, but when we're doing that. And the blood pressure was a little bit on the low side, so we're going to run a bolus of a litre through, if you can do that.
Yeah.
And I'll hear it wait while we do that. We'll see how we go over the next 5 minutes.
Beautiful. So that litre of fluid is running through now. Let's do our second set of box.
Yes. How are you feeling now?
My throat's really itchy.
Wow, so you're getting worse, not better.
Yes.
Okay. And what's the odds like now?
So I'll just come back. She's tachycardic at 120.
Oh,
Blood pressure is 89/46. Rest rate is 24. SpO2 is 93. And temp is 36.8.
all right. So I'll just have another quick look into the chest there. We'll just lean you forward. You're a little bit wheezy there, aren't you? Okay. And how's the stridal going there at the moment?
No stridor at this stage.
Okay, that's good. So what we might do, if that's okay, is to put a nebulizer up to give the adrenaline burst, because that's always the most important drug. Same deal into the thigh, intramuscularly. And if we can run a nebulizer at 10 litres of oxygen and 5 milligrams of insulin, we still got the fluid going.
Yeah, so fluid's still going through, just confirming I've got 500 milligrams of adrenaline, and I'm giving that into the thigh, and that is the second dose.
And we'll just call the ambulance because this is the second dose, and even if she settles down, we'll be in the hospital.
Beautiful, no worries, and I'm just going to start that nebulizer now.
So we're gonna look at that, all set up.
So nebulizer's hooked up with some self-butyl going through. I'll just step out and call the ambulance.
Great, thank you, and I'll just wait here while you're doing that.
Cool, so I've called the ambulance and they are about 15 minutes away.
Fine.
Should we do a third set of obs?
Yeah, so it's been 5 minutes, isn't it?
Yeah, it's
Since we
been
gave
about
it
5 minutes.
Okay, cool.
Beautiful. So third set of obs, we look like we've got some improvement here. The heart rate is 115, is 115. The blood pressure is 110/55. SpO2 is 98%, still on that 10 litres of oxygen. Rest rate's 20 and temp is 36.8. How are you feeling, Jane?
Much better, my itchy's gone.
Oh, beautiful.
I'll just have another listen to that. Okay, if I can. There we go. Good. Yeah, can't hear anything, that's good. All right, so we'll just
Lovely. Looks like QAS is coming in here. Do you want to do the handover?
actually, you know what? Because I've heard you know about ISPAR, I think it would be good for you to do that.
Beautiful. It's something that I prepared earlier. Hey, QAS officer, am I handing over to you? Beautiful. So this is Jane here. She's a 44-year-old female with suspected anaphylaxis. She does have a history of being anaphylactic to nuts, and she was trying out a new cafe today and started complaining of an itchy throat and a bit of a cough happening. Her friends, being the good Samaritans that they were, brought her into the urgent care. On presentation to us, she was mildly hypertensive and tachycardic with a global rash and some lip swelling and a bilateral wheeze as well. We have given 3 lots of 500 milligrams IM adrenaline. We've given 1 litre of fluids, and we've also started her on a neb of salbutamol of 5 milligrams here. Latest set of odds show some improvement with a heart rate of 115 and a blood pressure now at 110/55. We are requesting that she goes to the nearest available ED just for some ongoing monitoring here. Do you have any questions, queries, or concerns? No? Beautiful. Love that. Here's Jane. Let's get her on your stretcher.
Thank you.
And scene.
All right.
Alrighty, so that's an example of a scenario that we ran when we did a recent GP meeting, and what I've tended to do in the practices that I've been medical director of over the years is to try and run these as frequently as possible, even up to once a month, and just alternating. And sometimes I get different doctors to even run the resus scenarios, so we're all getting touches. What I've not done is tried to put pressure on doctors, because some people don't like being put on the spot, even though that's what happens when an emergency walks in the door. Often I'll ask people before and I'll give them some sort of mental preparation. Quite often I'll say, what did we do well and what did we not do so well? But the next thing that I'll do is I'll talk about some of the latest articles or the latest guidelines. One of the things that I've used a lot is the health pathways. So health pathways was started in Canterbury during the Canterbury earthquakes, and it's become a thing in Australia and New Zealand and also in other countries around the world. What happens is there are localized guidelines for many of the emergencies that we see, and I use those a lot. Sometimes I'll use local hospital guidelines. So we'll talk about a few pediatric emergency presentations. So we've got the Queensland Children's Hospital 3 kilometres away. So we use their guidelines because we refer to them. So it's a respect thing. And sometimes we use RACGP guidelines. But the most important thing is to have a reliable, preferably Australian guideline to use. So with anaphylaxis, we're in Brisbane South, so that's the health pathways that I use. We always need to consider anaphylaxis, even if the symptoms resolve spontaneously, if there's acute onset of respiratory and cardiovascular symptoms. So the respiratory can be upper respiratory, it could be the swelling of the tongue or the throat, or it could be asthma and cardiovascular symptoms, so drop in blood pressure, even cardiac arrest, or acute onset of hypotension, bronchospasm, upper airway obstruction after exposure to a possible or known allergen. So that's what we had in our resus scenario with the peanut. Not essential to the diagnosis, but we can also have skin symptoms, so rash, urticaria, angioedema, or even GI symptoms, so abdominal pain, vomiting, those types of things. There's a few differential diagnoses to consider. I've been caught out by a few. Mild to moderate allergic reaction. I remember at Royal Adelaide having some scromboid fish poisoning. About 3 or 4 people came in with sudden onset of, well, very quick onset of all over body rash, quite hysterical one night. I also remember number 4, panic attack, where we'd given a lady with cholecystitis some ceftriaxone, and then about sort of a minute or 2 later, she started, really getting kind of panicky and wheezy and breathless. And I was thinking, because she had a past history of anxiety and panic attacks, could this be a panic attack? Could it be an anaphylactic reaction because I've just given her IV antibiotics? If I think anaphylactic reaction, I give adrenaline. Unfortunately, it was a panic attack, so it kind of went the other way. And luckily, the boss came on and picked us and gave us some midazolam to calm her down. But there are some differential diagnosis that's important to know about. When we're managing anaphylaxis, there's not too many things to give. We often lie the patient flat unless they're a little bit breathless. If I'm not sure, just like with meningitis, if I'm not sure about meningitis, they get the dose of either penicillin or ceftriaxone and they go to hospital. If I'm not sure about, if I think it might be anaphylaxis, I give the adrenaline because it's an inflammatory cascade. If I give it early, it nips it in the bud quickly. If I let the cascade start going like this and faster and faster and faster, then it's really hard to get on top of. Sometimes we give oxygen. Oftentimes we'll put in an IV access, and sometimes we'll have to give antihypertensives. Oh, sorry, we'll have to give fluid boluses. If the patient's wheezy, nebulizer. If there's upper airway obstruction, sometimes we have to give nebulized adrenaline. And the scenarios that we always worry about is people with asthma that's uncontrolled because the mortality rate is increased, but also patients on beta blockers. Sometimes we have to give glucagon too. Say they settle down after a dose of adrenaline, and we watch them for 4 hours, and we want to discharge them. It's important to make sure the patient has an EpiPen and knows how to use that and has an action plan. If we're not sure why they had an anaphylactic reaction, it is good to refer to an immunologist. If it's a medication-related anaphylaxis, to inform the TGA. We make sure their asthma is well controlled, and if we're not sure about the suitability about sending them home, we transfer patients to emergency department. In New Zealand, where I'm from and trained, the government pay a $200 item number for patients who have given themselves EpiPen for anaphylaxis. And if they respond within a few minutes of that, they can come to the urgent care and we observe them for 4 hours, and we have to put a drip in while we're observing them. Used to be, this is back in the day, and this is why it's good to review things, that if someone had an anaphylactic reaction, we would send them to hospital because of biphasic reactions that happen 12 hours later. Actually, biphasic reactions can happen up to 3 days. So, it's not just 12 hours, but most of the clinically significant ones happen within 3 hours or 4 hours. So if certain conditions are met and the patient is stable, it's safe to send the patient home. And the 5 risk factors in a systematic review that were found to be associated with biphasic reactions were a long time to the first dose of adrenaline, a previous history of anaphylaxis, severe symptoms, a number of adrenaline doses. So if I need to give 2 adrenaline doses, I'm sending the patient to the hospital, and also an unknown trigger. So here's a basically protocol for anaphylaxis that we've given you the link to. So I'm not going to go through these because it's a busy slide, but I encourage you to print that out and put that on your research trolley, just in case you need to refer to that. Second medical emergency that I want to talk about today is bronchiolitis. So I've just picked a number that come into our urgent care centre, and also I see as a country GP when I was working in the Barossa Valley. So we will see the mild bronchiolitis and be happy to send those home. The moderate ones, it's important to know what a moderate one looks like, presentation, because sometimes you'll have to admit that to your local hospital. So if a child has moderate bronchiolitis, often their respiratory rate is increased, and I'm often concerned when the respiratory rate's more than 60, and there's increased work of breathing with nasal flaring, tracheal tug, saturations between 90 and 92, and difficulty feeding. So the big worries for me is the kid's looking a bit blue, and if the kid's not feeding, I certainly want to think about oxygen and also nasogastric tubes. This is the Queensland Children's Hospital guidelines on diagnosis of and management of bronchiolitis. Again, busy slide. I'm just putting it up there for your reference, but just kind of honing in on the ones that we're able to manage. Here we go. So with mild bronchiolitis, it's especially important to count the respiration rate. It's important to try some normal saline nose drops because children are obligative nose breathers up until 6 months. And if they settle down and they don't have risk factors for deterioration, it's quite safe to send them home. And it's usual that bronchiolitis gets worse for the first 2 days. It can kind of keep being quite nasty up to day 5. And sometimes with parents, I'll see the kid every day if I don't really want to admit them, but I'm still a little bit worried about them. The big ones that I do worry about are the ones that were born prem, the ones that have a low weight compared to what we would basically expect. Also kids with things like Down syndrome. So you'd worry about those ones. So under 1, often it's bronchiolitis. Between 1 and 5, it's preschool wheeze. So there are different protocols for that. When I was going through my training, it was asthma after 1. Now it's 1 to 5 preschool wheeze, and after 5 asthma. Different rules for that. Another busy slide, but it's just for you to cut and paste. But we're really interested in the mild to moderate preschool wheezes because they're the ones that we can manage in our primary care, and we don't necessarily have to send to hospital. So thanks to Ariel, Ariel was fantastic with setting up our resus trolley and our nurse-initiated protocols. We've got nurse-initiated protocols for salbutamol. So with salbutamol, we give, if it's mild, we give a dose, and a dose is 6 puffs. And you give a lot of, we don't use nebulizers so much anymore, but it's spaces now.
Yeah, it's definitely been a shift in the last few years of moving from your nebulizer into your spaces, which was a big learning curve for me as well.
So if you have a child with mild asthma, you give a dose of Ventolin, so that's 6 puffs via the spacer. And you'll notice here coming down, once they're more than 1 hour between doses, then you'll start to space things out. But what I've noticed with the protocol here is when they're more than 3 hours between the Ventolin doses, then you can consider discharge. It's different advice from asthma. When we go across to moderate here, we're giving burst. So actually that's 6 puffs every 20 minutes times 3. So that's over an hour. And then we get it so that they're having more than an hour between doses, pop them in short stay. And then if it's more than 3 hours between doses, then they can go home. We're not actually giving steroids or oxygen unless the presentation is severe, in which case they would be admitted. And this next one is childhood asthma. So we're going from preschool wheeze to next one is asthma. So we can easily manage mild asthma, but it's the moderate ones that we need to watch out for because we're getting on that slippery slope towards not really wanting to send them home, especially at night when their natural steroid levels go down. So their saturations start to drop, they start to get tachycardic and tachypnea, and they start having accessory muscle use. Another busy slide just talking about the Ventolin and also the steroids and the ipratropium bromide. So when we are dealing with children under 5, we use 6 puffs of Ventolin. And also once they hit 5, we can start using the Atrovent, the ipratropium bromide, and we're using 4 puffs as a dose, and a burst is 4 puffs times 3. With prednisolone, we don't use that unless it's severe, but you'll notice there's a bigger dose on day 1 and a smaller dose on day 2 to day 3. Next one we'll talk about is asthma. So that's diagnosed after 5. Another busy slide for reference, but we're basically coming down here to mild. We would give a dose of 6 puffs. If the child is 5, if the child is 6 and over, it goes up to 12 puffs. If they're improving at an hour, we send them home with an action plan. You can see with moderate here, you give a burst, which is 3 doses every 20 minutes, also with some Atrovent, and you give steroids if it's moderate. So preschool wheeze, you don't if it's moderate. With asthma, you do. And when there's more than 1 hour between salbutamol doses, it's safe to look at sending the patient home. With action plans, I think the chemist doesn't like me for this, but I will write an action plan on the actual script, just like I will write a GTN action plan. I write that out so it's printed on the patient's medication so that if anything ever goes wrong, it's documented that the instructions are there for the patient. Another busy slide about the different medications for asthma, but just narrowing it down to this. Age 5, it's 6 puffs, sometimes every 20 minutes times 3 if you are mild, but over age 6, it goes up to 6. It goes up to 12 puffs times 3. Sorry, if it's moderate. With the asthma, when it's moderate, you give the steroids. Higher dose day 1, lower dose day 2 to 3, and you can extend to day 5. But once you hit 5 years old, we're giving some ipratropium bromide. Next one we're just going to touch on is VT, and we've got 5 minutes to go, so we'll start to wrap it up soon. So every year in urgent care, we do an 8-hour CPR course, which I'm sure you will do quite regularly. But the reason for putting up this protocol, which hopefully you'll have on your resus trolleys, is this is a nice scenario to put up there for doctors. So, basically with these, we don't have to get the dummies out. We don't have to make it too professional, but it's just coming to the resus trolley, having a scenario, having your brain think about these protocols, and then having a debrief afterwards, so that if the situation presents to your rural general practice, you'll be familiar with what to do. Next one we'll just talk about, and probably this is the last one we'll talk about today, is presentations for COPD. I was involved in Southeast Queensland in a hospital that had one of the highest readmission rates in the country, identified by Stephen Duckett. And what they found was that if they engaged psychologists, physiotherapists, local GPs, that they decreased the readmission rate for COPD by 48%, which was an absolute amazing turnaround. What's been happening in England at the moment is patients with COPD can go into their community pharmacist who's been having extra training and get COPD packs where they start amoxil and prednisolone if they can't get into their GP, and that's having some amazing positive effects of keeping people out of hospital. So a few things I'd like to just highlight, just in this, again, busy slide, but we'll just focus on the bits that are really important. So if people have COPD and they're coughing more and they're having more phlegm or thicker phlegm, it's important to start them on 4 to 8 puffs of salbutamol every 3 to 4 hours via the spacer. And it's important to teach them about that. But if things are not improving with that, it's important to commence steroids for about 5 days and stop. So mild to moderate COPD is something that the general practice, in the general practice and also the urgent care, I think can do really well for. What we found in the study for the Southeast Queensland Hospital was there's a lot of anxiety involved, and if you can sit the patient down in short stay for 3 or 4 hours and make sure they're safe and do all the things that you would do in hospital, you can keep people out of hospital. These are the conditions where I'd be worried and I'd send patients to hospital, or if I was in the country, I'd admit unto myself, is there was symptoms were obviously severe. There was swelling of the ankles. There was saturations of less than 92% if they weren't on oxygen. And their shorter breath is much worse at rest. High fever, altered mental state, other comorbidities, and they're not able to do their normal ADLs. Anxiety is an important one, and this is what I find, especially if I know them and I can admit them, well, I can keep them in the rooms for, several hours and, encourage them to calm down and they understand what's going on. Often I don't need to send them to hospital or admit them under myself. This is the COPDX guidelines, which I think will be a fantastic thing to talk about in your meetings. And it just talks about the benefit of interventions like LAMAs, Spiriva, steroids, non-invasive ventilation, hospital in the home, and also the whole thing about the multidisciplinary care plans. And often what I find is when you see patients in an urgent situation and you've got some time to spend with them, you can go through these types of interventions and just discuss what the latest basically trends are in treatment. Patients really appreciate that. So we've got about 3 or 4 other scenarios that I've put up there. I knew we wouldn't get through them all today, but I put them there and the resources because what I'm hoping, if I see you at a conference that you'll, and you come along tonight, that you'll say, I heard what you talked about today. We went home, we looked at our resus trolley, we made sure it was, kind of had all the stuff on it that the rural faculty suggested, and we started running resus scenarios, and we started using some of the documentation and protocols that you talked about. That's what I'd love to hear. So I've put a whole bunch on there so that hopefully if you've got meetings coming up, you can start that. So we started today talking about my basketball career and how we used to practice certain scenarios that were unlikely to happen, but they could happen. And one of them came up and we actually managed it and we won the game. So just like that, we practice scenarios in the resus room using the resus trolley so that when these things come in, we can manage them. So thank you all for your attendance tonight, and look forward to saying hi sometime down the track. And thank you, Ariel.
Thanks, John.
Thank you. Thank you so much, John and Ariel. That was a very informative webinar. Before we just end, John, there are a couple of questions in the Q&A box. I'm not too sure if you can see those. I can read those out. Why are some medications in red? I think that was when you were showing those pictures of the resus trolleys initially
Sure.
in there. Yeah.
Thank you. So we just wanted to highlight, the tensions that we have, but with all the different types of doctors that work with us, and some of them are more skilled than others. And as a medical director, I'm kind of responsible for what's on the resus trolley. So if I have medications that some doctors don't know how to use properly and they use them and we have a bad outcome, I might be called to account. So I just put in red the things that we've chosen not to have on our urgent care resus trolley. If I was a country GP, I would have all those things because that's what's expected of me. It's a rural general practice guideline.
Fantastic. And if some of the GPs that have joined us this evening would like more information about urgent care courses, where can they go?
Yeah, so I would love if you would be able to give your details to Dimitri, because we've got this postgraduate certificate of urgent care over the line. So we're just developing the resources right at the moment. We hope to have it done by sort of April, May next year, and sort of available to start. We have talked to basically the chairman of the board for RACGP last year and the acting CEO. So they were keen to support this. So if you could give your details to Dimitri, and as soon as we've got something concrete that you can enroll in, we would love to have you as part of that. We're also just going to mention this as over the last sort of 18 months, we've traveled to different parts of the country and ran urgent care courses. We plan to continue to do that. The reason why I put mine and Ariel's email address in the front there is that we are keen to do that and to teach this type of material. So you can reach out to us as well. But if you give all your details to Dimitri, we will be, once we get that course up and running, we'll let you know.
Fantastic. Thank you so much. And just a quick reminder, we have gone a little bit over, to please complete the evaluation that will pop up in a moment when the session ends. It really just does take no more than a minute to complete. Certificates of attendance will become available on your CPD statements within the next few days. If there are any non-RACGP members who would like a statement of attendance, please email rule@racgp.org.au. And that concludes our webinar series for 2024. We do look forward to welcoming you all next year. I have also in the chat just popped in a web link to our webinars for next year for February, March and April. In March, there will be an emergency medicine case scenario webinar presented by Dr. Anthony Wong, which is part 2 of his webinar that he presented in August this year. So we hope that you could join us for that. Thank you again, John and Ariel. And yeah, for the rest of you all, have a great evening and we'll see you soon. Bye-bye.
Bye-bye. Thank you.